Good evening, everybody, and welcome to another edition of Smart Residence Learning Program. This is the second back-to-back. Since yesterday we had the Urology Armamentarium on the upper tract, and today we have planned the Urology Armamentarium dealing with the lower tract. To address this, we have Professor Dineshan, who is the Professor of Urology at the Calicut Medical College in Kerala. He is a very fine teacher who is most sought after for all the examinations for MCH and DNB. So he will be talking to you about the lower tract instruments. So I think the residents will first be asked about the lower tract and then we'll move on to the upper tract. So this class is going to be very important. Now with this introduction, I would now request Dr. Arun Chawla to introduce Professor Dineshan to the audience. Over to you, Dr. Arun Chawla.
Thank you, Dr. Patience. To introduce
Arun Chawla is having some connectivity problems. Arun?
I am there, sir.
Yeah.
Okay. So Dr. Dineshan is, the professor at Government Medical College, Calicut, and he did his MCH in the year 1993. Has been very active in the state association and the zonal association of urology at the Kerala and as well as the zonal level. He was awarded fellow of Royal College of Surgeons of Glasgow for his achievements in urology. He has been evaluator for the MCH urology exams by the National Medical Commission and is currently examiner, as has been examiner for the last 12 years, both for the National Board of Examination as well as the MCH examination. With this, I like to mention from my experience of working with him for the last many years, a very astute clinician, very deft surgical skills, a great teacher and accommodation to the core. I think today's class will be very valuable and you will see that he will cover the lower armamentarium very nicely and from the examination point of view. With this, I hand over to Dr. Dineshan for the further proceeding. Over to you, sir.
Good evening, Kashav, Arun, and very good evening to all of you. At the outset, let me thank the Urology Society of India for giving me an opportunity to talk to you about lower tract armamentarium in urology. Now, in every exam, not only in every exams, every urologist start the training with the lower tract and urology, endourology, with the telescope, the cystoscopies. They always start with scopies. So that is exactly what makes the difference between a general surgeon and a urologist. So you start the endoscopic work. So you must be very thorough. Everyone must be very thorough with the endourological equipments and how to handle them, how to clean them, how to maintain them. These are the basic things each and every one of us should be thorough with. Not only knowing that thing is not enough, you have to know how to maintain it properly, how to clean it. That is the basic thing, how to clean it properly. And all those things you must be very, very thorough with. And the troubleshooting with all the equipments also should be very thorough. So now we will start the things with lower tract endourology. I'll go with my slides. Can you see the slides?
Yes, yes, we can see.
Okay, okay. Now, okay. Now we'll start with the telescope first. Uh, Starting from the original days of incandescent bulb telescopes, now it has become more developed, more precise, with the mainly with the introduction of the rod lens system. Actually, the Hopkins system has revolutionized the whole endoscopy. Previously, this cystoscopy was very primitive with the old the battery operated light system. And now with the introduction of the rod lens system, the Scopius telescope, the telescope has become revolutionized the lower tract endourology. And now the telescope has got it has got the rod lens system. Actually, in the initial the original rod lens system, which was which started with started the transition, was there the rod lens was actually acting as the lens, at the rod shaft was acting as the lens. And later on, when with the introduction of the Hopkins system, the space in between the rod lens was acting as the lens. So that is improved the clarity and the visibility and the image. And the standard telescope, you have different you all of you are aware of all these things, the different depending on the area visualized, you have the 0 degree, the 30 degree, 70 and 120. These are the basic original standard telescopes. The 0 degree is the forward viewing, the 30 the for oblique, and the 70 and 120, many of the junior consultants and trainees are not very familiar with these two because of specific reasons, the lateral viewing and the retrograde viewing. And all these telescopes are color coded. You can see the color coding here. The 0 degree is standard, the green, and 30 is red, and 70 is yellow, and 120 is white. And all the telescopes are of standard length to accommodate to different combination of instruments, and it is 30 centimeter and 4 mm diameter. That is the standard measurement of each telescope. And rod lens system, I have already told you about the Hopkins. And now you have the most of the telescopes you are using is the Hopkins second Hopkins 2 system. This is the advantage is mainly it is better image quality, better contrast, and the better viewing angle. That is the most important thing, because in each in the original rod lens system, actually the image viewing angle was only 90 degrees, or 45 degrees on either side of the axis of the scope. That is 0 degree, it is forward, 30 is for oblique. Whatever is the axis on a 45 degrees on either side, that is 90 degree. That was the viewing angle. But with the Hopkins 2 system, which I have explained, with the lens, the air column air in between the rod lens acting as the lens, is rods acting as the lens. It has improved the whole thing, and you have a wider angle of vision, and that is the reason why you don't need a 70 degree scope now to So whatever the 70-degree scope, actually usually the 0-degree was used for actually to see the urethra up to the bladder neck, and then to scan the the lateral walls, you use the 70 degrees, and the base usually you scan by the 30-degree. And also for the resections or the procedures, you use the 30-degree. So when you have a larger, wider vision angle, the 30 itself, nowadays the 30, the Hopkins 230 will do the whole job of 120, sorry, the 70. So 70 is nowadays not routinely used except in certain specific situations that I will come to later when discussing with other equipments. About 120, you have the 120 degrees. The olden days when we were all trainees, the standard question was, which is the blind area of bladder? And the standard answer is the anterior wall close to the neck. So that was the blind area. And to visualize that area, you needed this 120-degree scope. So now with the introduction of this flexiscopes, now it's not a blind area. It's not. So I don't think anybody will buy a reverse viewing scope, that is the 120 scope, for all these things. So that is the angle of vision. And now another advantage of this Hopkins 2 system is that the telescope is that it is autoclavable. So the sterilization process is much more simple and effective. So these are the advantages of Hopkins 2. Now coming to the sheaths. You have an array of sheaths depending on your need to use as the diagnostic scope is using procedures with the other equipments where you want to pass other equipments along with this, like biopsy forceps, lithotrites, and other things. So depending on that, you have different types of cystoscope sheath with different specifications. These are the standard. Now the nomenclature has changed. We have olden days, the 17 is the type of number of, this is a newer nomenclature, 17, 19, 20, 22, and 25. Previously, we used to have 23.5, 17 was green actually. So now this is the standard. Now this is the nomenclature. This 17, 19, that is the diameter of the French size. 17 French to 25 French, and it is all color coded with yellow. 19 is green, 20 is red, 22 is blue, and 25 is white. And the standard, all these things, all these sheets have got a standard size of 22 centimeters. And now coming to the different, see, now you can see the base, that proximal end of that sheath where you have you fix the bridge. You have the inlet and outlet tubes, and you can see to mark these things. You can see that it is 22 French, and you can that 22 denotes the size of the sheath, that is 22 French, and the diameter means it is actually the 3 times the radius, that is 1/3 is the 1/3 in millimeter is the radius of the sheath. But it is not actually a pure circular, it is almost an oval, but it is always the French size is calculated as any instrument. The diameter is 1/3 of the French size, millimeters. And the 2 digits before below that denotes the largest size of the equipment. 2 equipments you can pass with this inside this. That is 6 French each. Either any equipment, any ureteric catheters or any other other accessories you can pass 2 simultaneously. This is the largest size, and the other 9 you can see here. That is a single large equipment, the single one which can be passed, the largest single equipment which can be passed through the working channel. And you can see the color coding also. And now coming to the obturator, you have a different types of operators here. See, all the operators are color coded according to the sheath. The same color code for the operator is used. The sheath is used for the operator also, so it is very easy to identify the which is corresponds to the operator. The only thing is why the reason why you need is the operator is that the beak, because of the beak, you have the beak of the sheath which is curved slightly dorsally and it is smooth. So if you are passing it without the operator blindly, it may injure there is a chance that it may injure this urethra. So you have to make it pass the operator. And here there is a difference between the 17 French operator and other operators. All other operators have are longer than the 17 French. 17 French operator is short and rounded. This is our oval. These are all longer ones. And this is 17 French operator doesn't have a groove at the tip. I cannot. This photograph doesn't show that. You have for the all other operators, you have grooves over the dorsal part of the operator tip, so that it will help the egress of the fluid. And for the 17 French, you have a small opening beyond near the beak, so to allow the egress of the fluid. So and the beak is always shorter in 17 French, but it is longer in all other sheaths. So the disadvantage of this longer sheath is longer beak is that when you are doing a female cystoscopy, when you enter it, this is a female urethra, as you know, it is a very short one. So when you enter it into the urethra, the fluid will come outside through the beak, and urethra will not get distended. So to prevent that, you can always use a 17 French sheath, or you have to use a nickel adapter, or you can use some other instruments like where you have the tip of the is rounded. So instrument like an internal urethotomy. We will come to that internal urethotomy later. Sheath. Otherwise you will not be able to do a urethroscopy in a female with all the 19 and above sheaths. Especially when you are this is needed, especially when you are suspecting a urethral diverticulum in a female. That is where you may require a urethroscopy, the commonest indication for doing a proper urethroscopy in a female. Either you can use a 17 French, or you can use a nickel adapter. Now we'll go on to the bridge. This is a standard bridge. And again, the bridge is standard length is 6 centimeter, and it is a universal one. So you don't have bridges, different bridges for different sheaths. For every sheath, it's a standard. So it fits in with every sheath. And you have a telescope engaging channel, and you have a, depending on the type of bridge you are using, you can have either a single side channel or a two-side channel, or there are some bridges with no channels also, side channel also. This side channel will allow you to pass other accessory equipments like graspers, guide wires, catheters, urethral catheters, and other whatever flexible equipments, even lasers or whatever, laser probes, whatever equipment you want to pass, you can use it. Now we can move on to the most important part of the discussion is the TUR set. The TUR set comprises of the original resectoscope, the McCarthy standard McCarthy. It was a single sheath system where you have to intermittently empty the bladder. But with the introduction of the Iglesia system, where it is a continuous irrigation system, where you have two inner the sheaths, the inner and the outer sheath, and the working element. I will discuss each one separately, and you have the operators. And the standard telescope used is the 30-degree scope. And about when I discussed the telescopes, I forgot to mention, I showed you the pillar separately, the light pillars. Here you can see the light pillar. For each one, each make, you have a different this type of light pillar, which will accommodate the particular light cord. So if you have a different make of this light cord and pillar, there is a mismatch. You can either, there are certain adjustments which can use in a stores. If you remove the outer part of that sheath stores light pillar, you can use it for a volt, or you need an adapter for from volt to stores. You need an adapter. So that's another thing. And coming to the continuous irrigation system, you have an inner sheath and an outer sheath, the working element and loop. These are the basic components, and the accessory, the high frequency cords and other things. So I will take each one. And the standard sheets are the resectoscopes are 24 French, 26, and 27 and 28. These are all color coded with yellow and black, as you see here. Now you can see the inner sheath and the outer sheath. These are our different makes, have different configurations. Some of them have the inner sheath were connected with the inflow tube, but whatever it is, the inflow is always through the inner sheath, and the outer sheath has got the outflow. You can see, closely look, you can see the small openings with the tip of the outer sheath, and that will give you, that is the way, that is the how the outflow occurs through the inner sheath. The fluid goes in, and from the bladder through the small openings here, it will come through the outer sheath and then come out. And now the important thing is that you have a electrical circuit going on through the loop to the uh, uh, tissue, the prostate or the bladder, and the system has to be insulated. Otherwise, it will produce burns in the urethra and stricture. So to prevent that, you have the tip of the inner sheath. That is where through the inner sheath, that is where the loop comes. You can see that it is insulated with uh, Teflon and either Teflon or ceramic coating. The tip is made of ceramic coating, so that will insulate that it prevent the current egress into the sheath. That is very important. You have to always verify that it is intact before doing the procedure. Every time you have to see that it is intact, the tip is intact. And while assembling this resectoscope and while doing the procedure, always make sure that the outflow is proper. See that the outflow channel is open and it is flowing continuously. If it is not, you stop the procedure, remove the scope, and remove the sheath and verify that there is no clot in the that outlet channel. Flush it, and always see the tip of the outlet sheath where you can see that small pores, small openings. It is not blocked. Otherwise, if the outflow is partially blocked, you can intravesical pressure will rise, and you can land into all sorts of problems. We will discuss that a little bit later. So that is where the cleaning of the instruments after the procedure and during the procedure comes. You have to always make sure that it is well cleaned. There is no clots after the procedure. Also, if the outlet channel and the tip of the sheath is perfectly clean, devoid of all clots, everything. Now, in a TURP circuit, the procedure, how is the circuit completed? See, you have the electrical system coming up. See, from the loop, the current is going to the tissues, and from the tissues, it is going through the patient, passing through the patient, and then to the you have the base electrode, that is the diathermy plate, and through that the circuit is completed through the patient, from the through the loop, through the tissues, through the patient to the diathermy plate. That is how the electrical circuit is completed. And the next part of the system is the obturator. You need an obturator because you have the tip of the instrument is, you can see that it is sharp, so you cannot pass it blindly. Either you have to do it under vision, or you have to, if you pass it blindly, you need an obturator. And you have different type of obturators, either hinged obturator or a straight obturator, that will help you to pass the resectoscope blindly, or you will have to do it under vision. Now coming to the working element. You have the working element, you have two different, mainly technically there are two different type of working elements. And the working element, that is the active and passive. I'll come to that. And depending on the type of loop you use, the single stem loop and the double stem loop, you have a different type of working elements. And the diathermy pillars, you can see the black pillar there. This is the type of single stem working element where you can see this is the pillar here where your high frequency cord is attached. And for a single stem loop, single stem working element, it is coming to somewhere here. It is getting attached to this area. And coming to the active and passive loops, the working elements. You have an active working element means the loop is always outside, and you have to, it is finger operated. You have to pull it up, pull it into the, actively pull it to make the cuts. The other one is the passive one, but here the advantage is that you have the loop always inside the resectoscope. The disadvantage of an active, that is finger operated working element, is that if you accidentally activate the system, the diathermy with the scope inside, resectoscope inside, you may injure the bladder because this may get the loop is always outside. But it is said that technically it is a faster one, but depends on how you are using and what you are used to. They doesn't make much of a difference. And here you can see this is the double stem, actually double stem working element. You can see where this is the area where the high frequency cord is attached. And the passive working element is, again, this is the same working element you all use with the internal urethrotomy also, the system also. Now coming to the loop. As I have already mentioned, there are two different types, the single stem and double stem, but it doesn't make any difference actually. Even the double stem is active. There is only one active loop, the active stem, that is the longer one, which is directly connected to the high frequency cord. The other stem is always given for stability, always there for the stability. And again, you have color coding for this loops also. This is 24 is always yellow and 27 is brown. And depending on the thickness of the loop also, you have the thick and thin loop and the standard loop. Thin loops are always preferred when you need a sharp, precise cut, where usually it is used where in the bladder resections, tumor resections, and especially near the apex. If you want the resect near the apex of the prostate also, thin loop is always preferred. Thick loop, when you want to resect the large adenoma, thick loops are preferred. But it's not, these are all theoretical, but you must know all these things. Other loops are, you can see apart from the cutting loop, and the loop angle, the standard loop is 90-degree angle. And thing is that you can see the standard loop. Here you can see the standard cutting loop. You can see that angle of the loop, it is 90 degrees. So it should not be more than 90. That is, it should not be obtuse. If it is an obtuse angle, it will not. Actually, it has to, once it is, the cutting is completed, it should come inside the, just inside this sheath. So then only the tissue will get detached. So if you have an obtuse angle, it will not get, even if you complete the resection, the tissue will not get detached. But if it is an acute angle, it will go more inside, and chances of damage to the ceramic tip and the current transmission to the sheath can also occur. So it has always made sure that it is always at right angle. And you have the Collins knife where you can be, with which you can always make make an incision, and especially the TUIPs, transurethral incisions of prostate. And this is the ball electrode where this is used for when you have a large area, you can want to coagulate that area. Ball electrodes are always useful. Otherwise, if you want to do a point coagulation, either a loop or a Collins knife is enough. And some particular special types of loops are also available. Yeah, rather than this straight right-angled one, you can have something like a straight loops, which is theoretically it is said that at the dome, if you want to resect tumors at the dome, this straight loops are preferred. That again also it's a individual preference, but you must know, at least you must know about the straight loop also. This is the double stem loop I was talking about. This is the active stem where the high frequency cord is connected, and this stem is always for the stability. This is the high frequency cord. This is the area which is connected to the pillar. This is for the single stem loops where it is connected to the pillar, and for a double stem you have a different type of loop, high frequency cord, which is connected to the right, which has got a small hole at the right side, so that it get connected to straight to this active limb of this stem of this tube. So that's a different type of high frequency cord. And for a pediatric, all the pediatric resectoscopes, the hole will be on the left side, rather than here the adult resectoscope high frequency loops, you have the hole at the right side, and the pediatric you have the hole here. So that's the difference. And coming to a little bit of theory about the irrigation fluid use. Commonest irrigation fluid is used is glycine 1.5. This is glycine, and the other thing is distilled water. These things are always, these two things are commonly used. But all this distilled water as well as glycine are hypoosmolar. See, if you want to make glycine isoosmolar, you have to increase the osmolality, but then the visibility goes down. The other things are all mannitol, dextrose are not usually commonly used, and normal saline is used for bipolar resections. And the height of the irrigation fluid is you must make very sure that the height is kept at near 60 centimeter height from the table, so that you have adequate flow of fluid and the intravesical pressure is kept optimum, so that there is no excess fluid absorption and adequate vision is ensured. So a 60 centimeter height, if the height goes up more than 60, then the intravesical pressure increases and you have more water absorption. And then you have you go into the patient can develop a TUR syndrome. So the causes of TUR syndrome is that there is more water absorption, and the most common cause is the causes you can enumerate. The basic cause is that there is more irrigant absorption. All the irrigants are hypoosmolar. So the causes are, one, if you have perforated, if you have opened venous sinuses, the fluid directly goes into the system. And you can, and what this hypoosmolar fluid absorption will trigger land in, they can go into hyponatremia, then the consequent, and more hypervolemia, and they can go in for you can say that cerebral edema and things like that. So the prevention comes, see, first of all, you have to identify that you have made a perforation or a venous opening of the venous sinuses. Then once you make the diagnosis that the perforation or venous sinus is open, the next thing is you have to decide whether to continue with the resection or not. If you are towards the end of the resection, you can, if you can complete it within few minutes, within a short period of time, you can proceed with the resection and complete it as fast as possible. Coagulate the, otherwise you stop the resection, coagulate, complete the coagulation and come out. That is the best option you have. If, or the next thing is, if you go, if it goes undetected, then you have the patient going in for the florid TUR syndrome. Like the patient will start usually start with yawning, disorientation, restlessness, abdominal distension, pain in the hypogastrium. Then there will be bradycardia and sometimes convulsions. So hypertension because of intracranial, there's fluid absorption and the intracranial, that is cerebral edema. And sometimes if you are using glycine, the ammonia toxicity also may come and produce blindness or transient blindness also. So all these things you have to be careful about. You have to, especially, that's the advantage of doing this procedure under spinal anesthesia, because all these things can be monitored. And if you are doing it under general anesthesia, the early symptoms may be missed. So the first and foremost thing is the intravesical pressure should never be high. And the foremost thing is make sure that the outflow is continuous and proper. During every resection, make sure that the outflow is continuous, properly done, and the bladder is not distended. And if it is the outflow is not proper, always make sure that it is. Or in case in any doubt, if the outflow is getting repeatedly blocked, always it is better. And you are doing a resection larger gland, which may take a longer time. It is better that you do a suprapubic drainage also. And in an established the TUR syndrome, you will have to give the supportive treatment depending on the sodium level. The hypertonic saline, the diuretics, and other supportive measures have to be done. And the late problems you can develop is because of the hemolysis. They can go in for renal failure also. All those supportive treatment will come later on. So that much about, and the first and foremost is the outflow, the monitoring the outflow. Next thing is the detection of the capsular perforation, and how to, if you have missed it, if you during the resection, if you have missed it, the other signs are, see, one thing is you feel that the prostate is receding from you because the because of the extravasation of fluid into the periprostatic tissue, the prostate will get elongated. So you will have to, the resectoscope will have to move more and more inside towards the bladder neck, so that the tip of the end of the resectoscope outside the meatus will become shorter. If you see that, you have to be sure that you have to look again whether you have there is an inadvertent or the perforation which you have not detected. Another thing is that again, when you have a perforation which was not detected, there is the periprostatic fluid extravasation. There will be more gripping. The prostatic will grip more on the resectoscope. The movement of the resectoscope will be become stiffer, difficult. So if you find any of these things, you must think that you must always suspect a perforation and look for it and stage the procedure. So these are the preventive notes for the capsular perforation. Then another thing is about the operator jerk in tumor resections, especially when you are resecting the lateral wall, anterolateral, the wall of the tumors. You can, the operator nerve can get stimulated, and you can immediately see in no time you can go out, and sometimes you may the extravesical space, you can see the fat, and you may even land into the perivesical venous sinuses can be opened, and you can have profuse hematuria. So it is so always when you are resecting in this area, the jerk has to be anticipated. So how to get out of, how to prevent this? First and foremost is you have to anticipate this, and the preventive measures are, if you are anticipating this, the best option is to block your anesthetist to block the operator with the local anesthetic apart from the spinal anesthesia. Or you can ask them to do an anesthesia under general anesthesia with full paralysis. Then it can be prevented. Otherwise, you will have to, other methods are, you have to reduce if you are doing it still under spinal anesthesia, you can do the cutting current. The current can be reduced, or you can use blend or coagulating current for resection. These are all ways in which it may be reduced, but still you can have it Otherwise, and you can do the resection in a partially full bladder, so that expecting that once the bladder is not, anyway, it should not be over distended, but if it is partially full, the bladder wall will be little away from the obturator nerve, so that the obturator stimulation may be less. So otherwise, the best option is to go for, if you have the facility, you can go for a bipolar. Then again, the chance of getting an obturator jerk is less. So these are the ways in which you can reduce the obturator jerk. Now, going to the, what is urethrotomy? This is an equipment used for doing what is the urethrotomies. Two common situations where you use this nowadays is that if you want to pass a larger instrument like a resectoscope or any other instrument in a male patient with a narrow urethra. Otherwise, if you force a larger instrument, you are sure that you may injure the urethra, and you are asking for a stricture. So this is one of the indications. You have to cut the urethra, or in other situations, especially in patients with meatrostenosis in postmenopausal ladies, if you want to do a meatrotomy and a urethrotomy. These are the two common indications for doing this using the urethrotomy. The urethrotomy has got a shaft which is the size of this shaft when it is closed is 14 French. So at least you have to have a 14 French urethra to admit this. And the snow is at this area. If you dilate, if you turn it clockwise, this will get this dilator will get opened up, and the amount of dilatation will be displayed here in the dial, and the maximum dilatation possible is 45 French. And this is the blade you can introduce with the hand supporting, and once fully introduced, the blade will go into the groove. So once you introduce and dilate, then pull the blade slightly out so that it will come out and stay like this. So once the urethra is stretched and the blade is out, and you take this out, only the stretched part of the mucosa will be cut. So there won't be any deeper injury, and that is the advantage of this instrument. And here at the tip, you can see there is a small knob here. This is something which can be removed. And once this is removed, you have a small holder that is used for in the olden days, the dilatation, urethral dilatation was done using piliform dilators. I don't know whether anybody has seen now the junior consultants and the postgraduates may not have seen the piliform dilators, which is helping to negotiate a small narrow urethra that strictures. So a piliform dilator is passed through the stricture, and this can be connected to this Otis urethrotomy, and you can negotiate the stricture with the using the piliform dilator connecting to this. That is the use for this knob here. And some of the newer variants of this Otis urethrotomy has got a hole at the tip through which you can pass a guide wire also. So it can be negotiated through using a guide wire also. So these are all that much about the Otis urethrotomy. Now coming to another important part of visual internal urethrotomy. This is again used for two most important uses of this internal urethrotomy. Internal urethrotomy is to divide the strictures and bladder neck incisions. These are the most important areas where you use this. The components are, this is the working element is the passive working element used for the TUR sit. You can have either a single stem or a double stem, depending on whether it is the single stem or double stem. You can have the knife also. This is a single stem knife. These are single stem knives. You can have a double stem knife also. So these are the knives you can, common type of knife you use. You can have, you can see there are two different types of knife. One is the straight one. This is the straight one, and this is the half moon. You call it as half moon or semilunar, half moon shape. So this is the straight one is used for cutting the urethra, because here you use a 0-degree scope and a straight. You pass it up to the through the stricture, and with a downward movement of this hand, this proximal end, you elevate the tip of the knife and cut it. That is the way you cut. You pass this, you advance this through the advance this knife by the working element, pass it through the lumen, through the narrow lumen, and depress this part, so that this area will be elevated, and then you just release that, so that the stricture will be cut. And this part, this semilunar, that is the half moon shape knife, is used for bladder neck incision. The advantage is that you can cut the neck through the forward and backward movements, through even while introducing also, because if the bladder neck is very stenosed, you may not be able to introduce the even the cutting knife. So while you are passing the knife into the bladder through the orifice itself, it will cut. So you can forward and backward movement, both will cut the stenosed area. That is used for bladder neck incision. And this is the outer sheath. The advantage of this outer sheath is that you have here you have the tip is always sharp and rounded, unlike the sheath of the telescope, the cystoscope. There is no beak here. It is a sharp edge, and so you always require a obturator here. Otherwise, introduction of this sheath will be damaging to the urethra. So always introduce with the obturator into the urethra, anterior urethra, beyond the meatus, then change it, and then you pass this working element with the blade assembly, so that you will not injure this. And here you have every internal uretrotomy sheath, you have a side channel for passing an accessory equipments. Usually it is the guide wire with the urethric catheter, so that when you see a stricture, always pass a guide wire, then only cut. Otherwise, if you cut that without a guide wire, and you will lose the lumen. Usually you will lose the lumen, and you will be nowhere. You won't be able to identify the channel once you make the cut. So you may think that it is a easy the easy stricture to divide, but always make sure that you pass a guide wire and then only cut. So that is why you need this, and this rubber shot is for allowing the guide wire to pass and also preventing the backflow of fluids. And you can see the markings here, 1 centimeter. Here you have all the markings throughout the sheath, and unlike the cystoscope sheath, you have markings only towards the proximal part. Here only you have the markings. The markings are used for measuring in cystoscope sheet. That is 1 centimeter. All these markings are 1 centimeter apart. It is used to measure the length of the urethra, part of the prostatic urethra, especially in the cystoscope sheath. But those things are all obsolete now, because nobody uses. Most of the time, you use transrectal ultrasounds, but it is customary that the questions are asked whether why you have all these markings for in sheets. And there is another thing, you have a half sheath. This is again, this is the half sheath, which is always connected, which can be connected to the main sheath. The advantage of the half sheath is that once you cut the stricture and take the whole scope out, then sometimes your catheter may not go inside because of the urethra will collapse, the stricture will collapse, and it will not allow the catheter to go in. So once you assemble this with the the half sheath, once you complete the incision, you can take the assembly with the working element and retain this half sheath there. And through that, the half sheath always permits a 14 French. This will permit a 14 French. So you can see the groove here. This will permit a 14 French catheter, so that through this you can always introduce. Otherwise, another way of doing it is, if you don't have the half sheath, you can always, after you do the divide the this thing, you can pass a guide wire, retain a guide wire, and you can thread the catheter over the guide wire. These are the two ways in which you can put if there is a little difficult catheterization. But these are all when you use it for difficult strictures. But internal uretherotomy as such is indicated only in short segment strictures where there is minimal spongiofibrosis. In those situations, this problem will not occur. You will be able to pass the catheter straight away. But if you are in a difficult stricture, in a selected cases, it is not a standard indication. Difficult strictures, if you are forced to cut it, then these instruments, this outer half sheath may be useful. And where to cut? See, always make sure that you cut at 12 o'clock, because that is the least vascular area, and the complication rates are very, very low. That is least injury-prone area, because if you cut at that area, you don't have many vascular structures there. And if other problems, if you cut laterally, you may cut into the corporal bodies. So posteriorly, the spongiosa is very thin, you can extravase it also. So always make sure, technically also posterior cutting also is difficult, but it should not be done always at the 12 o'clock. The complications of internal uretherotomy is that if you don't do it in the 12 o'clock position, you can if it is slightly going by the side, you can injure the dorsal veins, dorsal vessels, arteries and veins, and cause profuse bleeding. And sometimes if you simultaneously injure the corporal bodies, rarely you can the patient can develop a high flow priapism. There are certain occasions where the patients have developed hypoplasia. So it is, if you have in the postoperative period, if you find that there is a priapism developing, so think that you have you have injured the corporal bodies as well as the dorsal arteries. So that's a rare, especially if you don't stick to that 12 o'clock position, is possible. And always when you, in short segment strictures, see when you cut it will epithelialize and form a neo urethra without without recurrence. But if it, again, if there is a dense fibrosis, chance of failure is very high. If you find dense fibrosis, always ask the patient to do a self dilatation at least for few weeks or months. But there are other things you may be asked in the exams, which nobody does nowadays because of the chance of failure is very high. Core through uretherotomies. Say when you have a long segment dense stricture which is blind ending, you can it is described, it has been done with very high failure rates. Core through uretherotomies, that is blind internal uretherotomy with a finger guided in the rectum, and you can use lighted urethric catheters or reflexoscopes from suprapubic through the bladder neck, so that it is otherwise known as cutting for the light. But these are all the historical, and I don't think anybody is regularly practicing it. Once in a while, in a difficult means stricture crippled, you may attempt, but you may be asked in the exams. So those are the situations where you can land into all these sort of problems, like injuring the vessels, priapism, and require this self-dilatation also. A few words about bipolar TURP. Again, here the thing is that you don't have that you have the bipolar cautery system is used, and you have a different type of loop here. So the cutting is not done through through electric current. It is by the cutting is by plasma, because of the once the electric arc passes through the loop, there is a plasma developing in that at the loop, and that is the plasma is cutting the tissue. So the tissue damage is much less, and there are different types of loops also. You have different types of two loops or a single loop with the active single loop, and the passive part is through the stem of the loop. So different types of loops are also used. The advantage is, one is chances of TUR syndrome is less, or if almost nil, but the fluid absorption can be still there in a hemodynamically compromised patient. It may still have cardiovascular effects, side effects. But the main disadvantage is that it is slow. When you may take even for a grade 1 gland, you may sometimes take an hour or so. So it's a slow resection. But the advantage is that that syndrome, chance of syndrome, TUR syndrome is less. So you must be familiar with the loops of bipolar. And again, as I have already mentioned, the jerk, operator jerk can be reduced with bipolar. Now, a few words about the stone crushing forceps that almost completes the lower tract. You have 2-3 different types of stone crushing forceps which is used. This is the single action jaw stone crushing forceps, which can be used. This lithotrite can be accommodated in a 25 French sheath, and it has got a it is a thumb operated. The serrated jaws will be here, and you can hold this. You use a 30-degree scope, and stone can be crushed using this. The disadvantage is that this is a flimsy instrument. If you cannot hold a hard stone with this and break it, this jaw will get easily damaged with a hard stone or a larger stone. Only small stones, some 1 centimeter stone, can be crushed with this. So that is the main disadvantage of this equipment. This is a single action jaw. The next is a stone punch, Moran-Meyer's punch. You have a outer sheath, that is there is only a sheath. There is no outer sheath. There is only a. This is not a continuous flow. If you are getting using it for a larger stone, once you break it, start breaking it, the field will become cloudy and the vision will be blurred. So in between, you will have to empty the bladder repeatedly. It's not a continuous flow. There is only a single sheath. And here also the tip is sharp. So whenever you introduce this, you need a visual operator, so that you can. So you put this is the sheath. This is the visual operator. You assemble it, and if there is any difficulty, you can pass this. You can pass a guide wire or even a laser probe if you want to make small fragments through this side channel also. So you pass this with the assembly with a 0-degree telescope, and then once you are inside the bladder, you remove this visual operator and pass this assembly and the scope assembly. This is the punch, and you can hold the stone with this beak-like structure and crush it into. You can use this handle, and this forward and backward movement is allowed, so that the stone is engaged here, and it can be crushed against this sheath. So that, and once you crush it, you have to use a Tomy syringe or an helical evacuator to so that you can empty the whole stone bits. The main disadvantage of this equipment is that you have to be very careful to fill the bladder. So before you introduce this, you have to fill the bladder, and once introducing this working element and the scope assembly, you have to close this. You have to pull this out so that this end is inside this outer sheath, the sheath. Otherwise, while using this also, you must make sure that you have not caught the bladder mucosa. To ensure that, the best thing is you hold the stone first, elevate the tip with the holding the stone, and rotate the handle by 90 degrees, so that you are sure that you have not caught before you crush. Make sure that the mucosa is not caught in between. Otherwise, chance of injuring the mucosa is very high. And this is the before you put it inside, always make sure that the bladder is filled. And this is one for one. This here also I forgot to mention that before you introduce, especially in females, when you are doing this Otis urethrotome, make sure that you fill the bladder before introducing this. Otherwise, chance of injuring the bladder is always there. Here also, you make sure that you fill the bladder before. And one more precaution is that you always close this handle so that the tip is always inside this, and it is released only when you are holding the stone. And once you hold the stone, after holding the stone in this jaw, elevate the jaw from the bladder base and rotate the handle by 90 degrees so that you make sure that there is no mucosa you are holding between. That is the only way you can reduce the injury, bladder injury. Another thing is Hendrickson's lithotrite. This is vestigial. I don't think with the introduction of laser and other stone punch, and I don't think nobody uses it, but at times you may get to see this in any of the exams. It's a crude instrument here and heavy. See, the difficulty with all the single action jobs, the lithotrite, mechanical lithotrite is soft stones and smaller stones. Here you have two jaws which are very heavy, and you can crush almost any stone except very hard stones with this. And this is passed after closing this, and this is passed blindly as a dilator. And you always use a 70-degree scope with this. That was what I was mentioning. When you have uses for 70-degree now is in Hendrickson lithotrite, which I don't think anybody is using it. And sometimes these two jaws get, unless you tighten these two screws very tight before introducing, sometimes this may get dislodged, and sometimes it may become very difficult to remove it. This is something you must just know what exactly it is. I think that most of the lower tract instruments I have covered. Something, I think few other things, maybe if anything is missed, you can I think that finishes today's discussion.
Thank you, Dr. Dineshan, for your comprehensive coverage of the urology instruments. I know it's very difficult to finish in one hour all the lower track. There are so many things which we would ask questions in the exam. It cannot be covered in 1 hour, but you have given what is the basic which all the residents would want to know in the lower tract endoscopy. If there are some questions, somebody raised their hand. Can I see? There's a question from Dr. Kim Mammon. He wanted to know about the telescopes with the various companies, telescopes, Karl Stoll's, Richard Wolf and Olympus endoscopes. What are the differences in the specifications of that? Can you take that?
I think Tim, can you just explain those things? You want to make a point because those companies make subtle differences in the especially the light pillars, the angle of vision, the 0 degree rather than 0 degree. Some of them make 5 degrees scopes. So there are certain minor differences in the between the companies.
No, they are basically one of the major differences in the locking system. The locking system in stores is different from the locking system in the Olympus. And there is a difference in the light pillar, as you had mentioned, that there are adapters which can adapt to the light cables of different companies. And the light pillars are different in Olympus and stores. The major difference is in the locking system, because if you have a Olympus telescope, you cannot use it for a store's equipment. Their locking systems are entirely different. And Dr. Yogendra Basu has asked, what is the maximum size of stone that can be broken by a stone punch forceps?
It can be even the size doesn't matter much because see the axis, if a large stone with an oval stone can be, you can hold it with the shortest diameter and break it into two. So it's depends on the how hard it is. Basically, a 2 centimeter stone you can always break. But if it is even if it is a 4 centimeter stone, if it is oval, you can hold it with the shortest diameter, break it into two, then you can always break it with the punch.
And how is the lens cleaned is another question. How is the lens cleaned?
Lens means you are telling the telescope.
Endoscope. Yeah.
Endoscope is to be cleaned in waters. You have to clean the. You have the best way is to clean in water, soap and water. The best way is to clean it, or other cleaning solutions are there. But the best is you have to mechanically clean it. That is the best way out. Clot everything and running water.
There's another question which is asking, like laser fiber firing, do we need the loop to lie outside during TURP? Will it cause damage if fired while the loop is inside and the pedal is pressed accidentally?
Laser fiber and loop. You are using the same thing simultaneously?
No, not simultaneously. He's asking like laser fiber which protrudes while firing. He's asking whether during TUR, whether if you bring that laser loop inside, does it damage? You had mentioned actually that.
Oh, loop inside. Yeah, if you activate the loop inside if it is inside, see, it is supposed to go inside so that you will, you have to make the full cut. But if it goes too much inside, then it can damage. It can damage. Definitely, it can damage.
No, there is a ceramic tip. That is the reason that protective tip is given, because the loop is going to excurse into the scope. But that ceramic tip will prevent the damage to the scope, and that is the mechanism which is created why the ceramic tips are given for protection only. I think that is the answer.
If it goes too much inside, it can damage the scope also, telescope also.
Yeah.
So that is the advantage of that. That is the necessity for always maintaining that 90 degree angle of the loop. If it goes too much, if it is an acute angle, it can damage. One is damaging the insulation. Second is damaging the telescope.
Then other question is how to prevent working element spark.
Again, you have to always check the high frequency cord. That is where you can always get a power leak. Always repeatedly, always make sure that there is no damage to the working the high frequency cord, and the active lead or active end of that active limb of the shaft of the loop. That is the area you can always get a leak currently.
Then benefit of bipolar TURP. I think you had mentioned.
I think benefit is see the syndrome is less, and you can do it for preventing of crater jerk. All those things are the benefits,
Then
major
sometimes
benefits.
recurrent bladder neck stenosis, how to cut the bladder neck stenosis.
See, always that is where you have to cut using cold knife. Always cut with a cold knife. Hot knife is it can recur. Make sure that you cut with a cold knife.
So I think those are the questions which came in the chat box. Thank you, Dr. Dineshan, on behalf of the USI. Thank you very much for spending time with us tonight, teaching the residents about the lower urinary tract armamentarium. Thank you very much.
It was a nice time talking to all of you. Thank you. Thank the USI for giving me this opportunity to share my ideas.
I think
Thank you.
Arun Chawla is traveling, so he had messaged me that he's traveling because he had some urgent emergency to attend to. He's going to Jalandhar, so he has conveyed your wishes, his wishes to you. Thank you very much.
Thank you. Okay.
Thank you, sir.